Good afternoon, everyone. So I'll be talking about the mechanism of resistance to RET TKIs and therapy post-resistance. So a brief introduction. As we all know, RET gene fusions occur only in 1 to 2% of non-small cell lung cancers, and they characterize adenocarcinoma variety, young never smokers. The RET proto-oncogene is located on the long arm of chromosome number 10. This encodes a tyrosine kinase receptor which has got an extracellular, transmembrane and an intracellular domain. Ligand binding to the extracellular domain leads to autophosphorylation of the intracellular domain, which then activates the downstream signaling pathways like MAP kinase and AKT pathway, which leads to accelerated cellular proliferation. RET fusions in this, the 3' end of the RET gene combines with the 5' end of a partner gene, and this leads to homodimerization, which leads to constitutive activation of the downstream pathways. So the treatment options have already been covered. In the first line, we have RET selective inhibitors, chemotherapy plus minus immunotherapy, and multi-kinase inhibitors. These multi-kinase inhibitors like vandatinib, cabozantinib, and lenvatinib, they were used before the advent of the RET selective inhibitors. They have got low response rates and short PFS. And the RET selective drugs have already been covered by the previous speaker. So now coming to the mechanisms of resistance to RET inhibition. The key mechanisms include either they can be primary or acquired resistance, and they involve the activation of the MAP kinase pathways through an alternative route. This could either be secondary on-target RET mutations which are interfering in RET binding, or there could be the activation of subclones of the tumor population which are driven by alternative mechanisms like MET amplifications. Another important point is multiple mechanisms can coexist in the same patient at one time. Coming to primary resistance, this is because of pre-existing mechanisms existing before the exposure to RET tyrosine kinase inhibitors. It can be seen in up to 23% patients, and this leads to very early progression with a PFS of approximately 6 months or less. A common mechanism is MET activation, which is seen in up to 15% of patients. Other mechanisms are KRAS mutations. The secondary resistance, this develops after the exposure to the MET inhibitors. These could be gatekeeper mutations or solvent front mutations. Basically, they inhibit the binding of the drug to the ligand. The gatekeeper mutations, this is applicable mostly in the multi-tyrosine kinase inhibitors, which bind through the gatekeeper, and mutations in these lead to prevention of the binding of the drug to the ligand. The solvent front mutations are the most important for the RET selective inhibitors, namely selpercatinib and pralatrexate. So in this, what happens is the RET selective inhibitors, these are not affected by the gatekeeper mutations. They are vulnerable to this solvent front mutations like G8110R, S, C, V. The frequency of these solvent front mutations is not known. There are other mechanisms of secondary resistance also, like acquired MET amplification, KRAS, FGFR2 amplifications, BRAF mutations. So basically the alternate driver mechanisms which lead to progress of the tumor. And this is a large study which looked at the mechanism of resistance to selective RET tyrosine kinase inhibitors in RET fusion positive non-small cell lung cancer. What they did, they basically looked at 18 such patients, and 23 post-treatment tissue or plasma samples were taken. And what they found that RET solvent front mutations and MET amplifications were the most common mechanisms for resistance. Off-target RET independent mechanisms like MET target amplification was seen in 15% of cases. Another important thing, they found that histologic transformation to squamous or non-small cell or small cell histology was not seen. Coming to RET fusions can also lead to resistance to other primary driver mutations like EGFR. So there is data stating that patients who have progressed on osimertinib because of RET fusions have done well with combination of selpercatinib and osimertinib. So what are the strategies to overcome resistance after RET selective inhibitors? One is combination drugs like selpercatinib and crizotinib in patients with MET amplification. Another mechanism could be second line chemotherapy plus minus immunotherapy. These are the some next generation selective RET inhibitors which are under trials, which could be active in drug resistant and drug naive situations both. They are undergoing phase 1 and 2 clinical trials. Also we have phase 3 trials are ongoing with selpercatinib as well as pralsetinib in the first line setting in metastatic non-small cell lung cancer with RET fusions, which will give an answer about the use of these agents in the upfront setting. Trials of RET inhibitors are also ongoing in the early stage non-small cell lung cancer in the adjuvant setting as well as in the neoadjuvant setting. Both selpercatinib and pralsetinib are being used. The future directions: identification of potentially targetable resistance gene alterations such as MET amplification or RET solvent front mutations implies that repeat biopsies will have a clinical value in patients at the time of progression on RET inhibitors. Upfront combination treatments may be explored like RET and MET inhibitors together, and development of next generation selective RET TKIs to overcome mutations will be an important thing to watch for. In conclusion, I would like to say that it is important that the inconsistent application of guideline based molecular testing, which is widely prevalent all over the world, this is a major challenge, as RET is only 1 to 2%, and we generally look for EGFR, ALK and ROS1 and PDL1. Many times we tend to ignore these less common mutations. As more and more actionable targets are identified, there is a greater need for using the multi-gene testing techniques. RET selective inhibitors, both selpercatinib and pralsetinib, have favorable efficacy in RET gene mutations, and they are recommended both in the first line setting as well as in the second line setting if they have not been used earlier. And next generation RET inhibitors are currently under development to overcome resistance to selective RET inhibitors. Thank you.